Neurology quiz number 109. Describe the etiology, clinical features, investigation and treatment of autoimmune encephalitis. Part 1 of 2. Autoimmune encephalitis comprises a group of disorders in which the host immune system targets self-antigens expressed in the central nervous system. Autoimmune encephalitis is at least as common as infectious forms of encephalitis in high-income countries. It is of two main types. The first type is caused by antibodies directed against cell surface antigen and is the most common type. The antibodies are directly causative of the clinical syndromes. The second type is associated with antibodies directed against intracellular or intraneuronal antigens. These are most likely an epiphenomenon and not directly causative. In general, the autoimmune encephalitides usually present rapidly over a few days to weeks. However, a more chronic course has been reported in some cases associated with LGI1, Caspr2, and Iglon5 antibody syndromes. Clinical features commonly associated with this condition include the following. Psychiatric behavioral. These include aggression, irritability, mood lability, hallucinations, and disturbance in the sleep-wake cycle. These are especially common in anti-NMDAR and anti-AMPA antibody syndromes. Cognitive. Clinical features include amnesia, confusion, disorientation, and confabulation due to involvement of the limbic structures, as in limbic encephalitis, LGI1, and NMDAR antibody syndromes. Seizures. These occur in most types. Fatiobrachial dystonic seizures are characteristic of LGI1 encephalitis. Caspr2 antibody encephalitis is associated with frequent focal seizures. Status epilepticus most commonly occurs in GABA A and GABA B antibody syndromes. Movement disorders. Patients with NMDAR antibody have a combination of chorea, stereotypic movements, and dystonia, which typically affects the face and mouth, but also the limbs. Anti-DPPX and anti-glycine antibody syndromes are associated with myoclonus and hyperexplexia. Disorders of gait are seen in Caspr2 and Iglon5 antibody syndromes. Iglon5 antibody can be associated with a PSP-like picture. Dysautonomia. Autonomic disturbances are frequently seen and include orthostatic hypotension, constipation, and abnormal sweating. Diagnostic criteria for possible autoimmune encephalitis. Diagnosis can be made when all three of the following criteria have been met. Subacute onset with rapid progression of less than 3 months of working memory deficits, including short-term memory loss, altered mental status, or psychiatric symptoms. Number 2, at least one of the following. New focal central nervous system findings, seizures not explained by a previously known seizure disorder, CSF pleocytosis, and MRI features suggestive of encephalitis. And number 3, a reasonable exclusion of alternative causes. It is to be noted that some types may not have CSF and MRI abnormalities, and the diagnostic criteria can be difficult to meet. The first group includes diseases with antibodies against cell surface antigens, and the various types are anti-LGI1, anti-NMDAR, anti-Caspr2, anti-MOG, anti-DPPX, anti-Iglon5, anti-glycine receptor, anti-GABA A, anti-GABA B, and anti-AMPA receptor. LGI1 antibody encephalitis. The median age of onset is 65 years. It is uncommon before the age of 50. Association with tumors is uncommon, but it can be associated with thymoma, small cell lung carcinoma. Seizures are very frequent and with severe disease. Patients can have several hundred seizures per day. Fatiobrachial dystonic seizures are short-lived, typically less than 2 seconds. Dystonic posturing of the arm, face, and sometimes the leg, and can occur several hundred times per day. Other seizures reflect mesial temporal lobe features like automatisms and epigastric rising sensation, but also more specific patterns such as piloerection, thermal sensations, and paroxysmal dizzy spells. Generalized seizures occur late in the disease and are isolated events. Cognitive abnormalities are prominent. Patients develop anterograde amnesia and some degree of retrograde amnesia. Psychiatric manifestations include euphoria, depression, and increased emotionality. Spinal fluid is usually unremarkable. Brain MRI is often normal but may show hyperintensity in the hippocampi and amygdala and basal ganglia. EEG shows clinical and subclinical seizure activity with a slow background. HLA-DRB1 is found in 90% of the cases. This slide shows a patient with LGI1 encephalitis. On the left side, the patient is experiencing a faciobrachial dystonic seizure, and on the right side is an diffusion-weighted MRI showing diffusion restriction in the right putamen and caudate nucleus. This video shows a patient with LGI1 encephalitis experiencing a left-sided faciobrachial dystonic seizure. NMDA receptor antibody encephalitis. This is more common in females in a ratio of 3:1. 50% of the patients are less than 18 years of age. 30% of female patients have ovarian teratomas, which are much less common in children and adults. 5% of cases occur a few weeks to months after HSV encephalitis. Psychiatric features are prominent at the onset with agitation, aggression, hallucinations, delusions, anxiety, mutism, catatonia, and insomnia. Many patients initially present to psychiatry and are misdiagnosed with a primary psychiatric condition. Cognitive dysfunction includes confusion and memory disturbances. Seizures are common, occurring in 70%, but are uncommon at presentation except in young men. Both focal and generalized seizures occur. Abnormal movements occur after 1 to 2 weeks, which can be complex and incorporate elements of chorea, stereotypies, and dystonia, especially affecting the face and mouth. Dysautonomia and hypoventilation reflecting brainstem involvement can occur and are a cause of mortality. MRI is normal in up to 70% of the cases. Abnormalities noted include cortical T2 and flared hyperintensity in the temporal lobe and hippocampus and the basal ganglia. EEG usually shows generalized delta activity. 50% exhibit generalized rhythmic delta activity with superimposed beta activity termed extreme delta brushes because of their resemblance to the delta brushes of neonates. CSF is abnormal in the majority with mononuclear pleocytosis and mild to moderate protein elevation. CSF antibody testing is important because in some cases the antibody is only found in the CSF. This slide shows an EEG which is demonstrating frontally maximal high voltage beta activity superimposed on frontally maximum delta waves, which is consistent with the extreme delta brush appearance. Caspar-2 antibody disease. This can present as Morvan syndrome and as a limbic encephalopathy. Both affect males more than females in a ratio of 9:1, predominantly from 60 to 70 years with onset over several months. Morvan syndrome is characterized by severe autonomic dysfunction, peripheral nerve hyperexcitability, neuropathic pain, insomnia, and prominent psychiatric impairments including hallucinations, agitation, and delusions. Seizures are uncommon. Coexistent LGI1 antibodies occur and approximately 25% will have a thymoma. Limbic encephalopathy manifests as prominent disorientation, amnesia, seizures without other coexistent antibodies, and low rates of an underlying neoplasm. CSF and MRI are often normal. EMG shows neuromyotonic discharges and is helpful in diagnosing Morvan syndrome. A significant number of patients are positive for HLA-DRB1, suggesting immune predisposition to the condition. Caspar-2 antibodies can be false positive, and significance should be given to high titers as well as CSF positivity. This video shows a patient with Caspar-2 antibody disease having muscle fasciculations and myokymia. This video shows spontaneous neuromyotonic discharges. MOG antibody encephalitis. These antibodies are associated with ADEM, which is an encephalopathy that particularly affects the pediatric population and presents as confusion and seizures. It shows white and deep gray matter imaging abnormalities, and 50% of patients are MOG antibody positive. Flames or unilateral cortical flare hyperintense lesions in anti-MOG associated encephalitis with seizures. This is a cortical encephalitis with unilateral or bilateral cortical hyperintensities. In some patients, these types can coexist with optic neuritis and longitudinally extensive transverse myelitis. This is an MRI of a patient with ADEM, an axial flare MRI showing bilateral globular hyperintense lesions in the cortical gray matter, centrum semiovale, and deep gray nuclei. This is brain imaging in flames. T2 flare axial image on the left shows hyperintensities involving the left frontotemporal cortex, and the right image shows gyral diffusion restriction in the same areas.